Hello.
My name is Sage.
I'm Connie.
Alright, and we're going to talk about Duchenne muscular dystrophy. So when we're talking about frequency, it's approximately 1 in 3,600 male births have the Duchenne form of muscular dystrophy. Between 400 and 600 boys are born each year in the United States with this. It does not really affect any specific ethnicity, but the basic defect is at the genetic level. Both of the muscular dystrophy syndromes result from mutations of the gene that encodes for dystrophin. Dystrophin is a protein that is product in the skeletal muscle. And then with this Duchenne's muscular dystrophy, dystrophin is absent within that skeletal muscle.
Alright, and so for the clinical presentations of Duchenne's muscular dystrophy, you're going to have a relentless progression of muscle weakness, usually death as a result of respiratory or cardiac failure. And then children will have a waddling gait, lordosis, usually frequent falls, a positive Gower sign, and then usually you're going to have enlarged calves, so it's going to feel firm or woody when you palpate it. And then in later stages you're going to have profound muscular atrophy, and oftentimes mental deficiency is common in Duchenne's muscular dystrophy. And then some of the complications of it is the contracture deformities of the hips, knees, and ankles, and then disuse atrophy, cardiomyopathy, and then obesity, and sometimes at times can be undernutrition. But as a result, respiratory compromise and cardiac failure can occur.
Yeah.
And then, so for testing to diagnose this, it's primarily
I can do it. Yeah.
Okay.
I'll do the testing.
Oh.
The diagnosis of DMD, we'll call it, primarily established by blood polymerase chain reaction, the PCR there, looking for that dystrophin gene mutation. You can diagnose this prenatally as soon as 12 weeks of gestation. Serum enzyme measurements, muscular biopsy, and EMG may also be a way to establish that. Serum creatine kinase levels are extremely high in the first 2 years of life before the onset of the clinical manifestations like weaknesses and stuff. If the child demonstrates any unusual characteristics, or there's a positive family history for DMD, and the PCR result is positive, you don't necessarily have to do a muscle biopsy.
Right. And then the prognosis for a positive test result is that Duchenne's muscular dystrophy it's not a curable disease, but its focus is on trying to maintain mobility and independence as much as possible. And it's important to maintain Duchenne's muscular dystrophy in order to avoid future complications. So Duchenne's, it causes muscle weakness, which is usually noticeable around 3 to 4 years of age, and it may also affect learning, memory, communication, and certain emotional skills. So most children with DMD usually end up in a wheelchair by the age of 12 or 13 years old. And in their teen years, this is when you're going to see the heart and respiratory muscle problems. So this can oftentimes lead to life-threatening complications. And so some new research that's going out with Duchenne's muscular dystrophy is that the Food and Drug Administration, they have approved some drugs for the treatment of Duchenne's muscular dystrophy. The first one is deflazacort, and this is the first corticosteroid which is approved by the FDA for this indication. And so this, what it does, it produces an anti-inflammatory and immunosuppressive effect. However, it does not cure this disorder, but it slows down the progression of the disease.
For nursing considerations, we chose to look at nursing diagnoses, which would be impaired physical mobility with that muscular skeletal impairment or weaknesses. We're going to be really cautious about that when we're moving the client, when we're thinking about their care plan and stuff. Risk for delayed development. There is a connection to DMD and learning disabilities, actually. Risk for obesity. That would be because of the sedentary lifestyle that occurs. By age of 12, it's generally that it's almost impossible to ambulate by yourself. So that's going to lead to a risk of obesity. And then compromised family coping. since it is a hereditary gene or gene-linked disease, it doesn't have to be necessarily, but for the most part it's hereditary. It can be really hard on the families when they get that news that, hey, maybe this is caused by something that I did, even though that's not the true case. That can be really hard. So getting to those family systems and coping with that, and then also since it's a prolonged disease process and it's a lifetime thing, that can put a lot of strain on those social family networks. So then we go into the parent and the patient teaching. Parents should always be involved in the making decisions for their child's care. That gives them some autonomy in that. They should be taught fall preventions and general home safety for their child. They need to be encouraged to have follow-up appointments for medical cares, especially when the disease process goes through. You get into a lot of cardiac and respiratory issues, so medical care, and then physical therapy and occupational therapy to help maintain the function of the kid. And then also they need to be taught about like the need for vaccines, like pneumococcal vaccines and influenza, because kids with this DMD are much more susceptible to respiratory illnesses. And then you should teach them that if there is a person with an active respiratory illness, that they need to keep their child away from that.
And then for the counseling portion of this, so genetic counseling is usually recommended for parents, sisters, and maternal aunts and their daughters because it is an inherited X-linked recessive trait. Women can be carriers of the disease without showing many identifiable signs of the disease.
Yep. Follow-up appointments is kind of what we were talking about with medical care, because it is respiratory and cardiac, that they need to be able to get that kind of help of that medical care. And then obviously the physical therapy, occupational therapy utilized as much to maintain that mobility.
Right. And then for medications to assist with Duchenne's, we're going to give them steroids, primarily corticosteroids, because this may improve the strength and the function of the muscles in people with Duchenne's. This also includes their lung function. So steroid options include prednisone, deflazacort, and oxandrolone. I cannot say this. And then for the special diet, a high protein diet is usually recommended. The main point is to have a nutritional diet that is similar to any growing boy. But severe constipation is usually a result of the muscle weakness, and so a diet that includes high fiber and lots of fluids should be included. And then once activity becomes restricted, caloric intake should be reduced because we want to reduce the incidence of obesity in these children.
Yeah, and then real quickly, just 2 or 3 sentences explaining the inheritance of this that is able for the parents to understand. I'm just going to read this off because it's pretty simple. MD usually occurs because it is inherited from the parents. However, it can sometimes develop on its own without any connections while the child is in the womb. It usually only occurs in males, about 1 in 3,600, but rarely in females. Muscular dystrophy can occur in any ethnicity or age.
Yeah.
All right.
I think that's it. Thanks
Thank
for watching.
you.